Hi, everybody. It's AJ Heitman, and this is the GEMS EMS Today show. Really special episode today. And I heard about this program, and I know we're going to do an article on it in GEMS, but you know what? It's so important. It's so timely that I wanted to move it right to the front of our guests on the EMS Today show. So with me, a bunch of people, first of all, but Dr. Kevin McKee. And Dr. McKee has with him a very unique combination. He has Scott Perryman, who is a captain and a PA, and you're with Metro Fire, am I right?
Yep, that's correct. Metro Fire in Sacramento.
So I'm very smart. I'm from Scranton, and I can read your shirt, so I'm doing really well. Well, here's the essence, folks. And Jim Page always said we should tell the essence up front. This is a program that was in the planning for community paramedicine for a couple of years, and then all of a sudden COVID came along. And the Sacramento County Department of Public Health got to the fire departments through the hospital council and said, hey, you know, we have a need and we don't have the resources. You guys have the resources. Do you want to help us? And this is an amazing program that essentially, and I'll turn it over to you in a second, Kevin, essentially came up online with a bunch of fire departments. We had Sacramento Metro Fire Department. We have Sacramento City Fire Department, Folsom Fire Department, Sacramento Airport Fire Department, Cosumnes Fire Department, and we also have involvement with the Sacramento Regional Fire Emergency Communication Center. So all those people got together, rigs, people, scheduling in basically a week. And the thing that got me when Kevin called me is the number of patients that they've been able to treat in just the last even couple of days. So Kevin, talk about the program, please.
Thanks, AJ. So yes, we were, as everyone is experiencing this COVID crisis, our Department of Public Health identified an immediate need to be mobile and to be able to get out in the community, and reached out through our hospital council, who then reached back to the fire agencies and says, can you help us? And we of course said, yes, absolutely. So we had been working on a mobile integrated health program with Captain Perryman here for probably about 5 years. And so we had some of the nuts and bolts put together, but we didn't have all of it. And so on a Friday afternoon, the Department of Public Health and our health officer had a meeting with the fire agencies, and we identified what this would look like. And it was April Fool's Day. Oddly enough, April 1st, so we got off the ground and we launched one unit right away because Captain Perryman was ready to go with his unit. And the other fire agencies got spun up very, very quickly and were able to identify firefighter paramedics and their cadre that were willing to come off of the line to serve on these units. And then we had other partnerships with local health plans who provided the PAs and the nurse practitioners. And so UC Davis provided some upper level residents, and Kaiser Permanente provided some physician assistants that were doing clinic work at the time, but were able to help us out on their days off.
So they're volunteering their time. Their hospitals aren't paying them to do it?
That's correct, AJ. So in order to make this work, there's a liability protection clause that has to be in place. And with a declared statewide disaster and a local disaster, our Department of Public Health is able to swear in and deputize these individuals as disaster services workers under the Governor's Office of Emergency Services. And through that swearing in and volunteering process, they have liability extension into the street outside their normal job duties.
And so, you know, the logical question is, you know, the support from the fire chiefs. That's phenomenal.
It's been amazing, honestly, really. I mean, having worked with these men and women for about a decade now in the Sacramento area, they've been a great group of people to work with. But with this particular project, before the question was even asked, the answer was yes, we'll figure it out.
Yeah, you know, I've always known that whole region has cooperated. You've been the fire service medical director for them for many years, so they all know you. And so it's a common leader for a common program. And God, I love that you even got the vehicles all lettered up and ready to go. So talk about your target audience, because really a lot of your target audience is something that's near and dear to my heart, and that's zeroing in on the nursing skilled care facilities.
Absolutely. So we do have operational priorities, and our number one operational priority is being an extension of the Department of Public Health into our community. And the Department of Public Health works closely with our assisted living facilities, skilled nursing facilities, memory care centers, probably arguably the most highest risk population. And so we can be mobile and engage with this Department of Public Health and those facilities to go into those facilities to perform brief medical evaluations and perform testing. And then we take those swabs with, again, the partnership with public health back to the Department of Public Health lab, and they run the results. And we're generally getting about a 24-hour turnaround on our results. And then those go back to the facility.
Yeah. And so how do you get your daily assignments?
So it's one of two ways, because our operational priority really is with the Department of Public Health, but we have other priorities as well, because not every day is full of swab testing. I've been able to work with some discharge planning groups through Kaiser, Sutter, Dignity, UC Davis, who have patients that were in intensive care units on ventilators, now on oxygen, that are in their homes. And because of local changes in the home health care policies, they have no ability to get providers into their homes to follow them up. So that's another thing that we're doing, is doing the discharge follow-up. So to get back to your question, it comes from two angles. All of the Department of Public Health assignments for swabbing and testing goes through Captain Perryman. He works closely with them, and all of the post-discharge follow-ups for the hospitals come through me. And we get together usually the night before, sometimes the morning of, and we discuss the day's activities and we assign the tasks for the day.
Now, you said when we were talking about that, that really perked my curiosity. So let's say we have an elderly woman who is discharged home. She's not positive anymore. She's been off the vent. Is she safe to be around her family, and she's on O2? Is that right?
Some of these patients are on O2. Some of them are not. One I'll see this afternoon is still on oxygen. She sounds very frail still. And it is, and that's really the $100,000 question, AJ, right? We really don't know when safe is safe. And so we're going with an abundance of caution.
Okay.
We're still asking the family members to mask up when they go in the home. We are going in full PPE and N95s, full face masks, gowns, double gloves. And so when we go into their homes, we're protecting ourselves as well.
So they're still pretty frail, and they're by themselves. How do they get around? How do they eat?
Well, we identify all of those needs when we follow up with them, and they're working closely with their hospital organizations. So if we identify needs outside of what would normally be our standard, I just asked this lady today, does she need food? Does she need resources? Is there anything else we can get for her? We'll go and we'll get that, and we'll bring it to her house. We've written prescriptions from their homes and refilled meds. And even last week, one of our PAs was in a home of a brand new diabetic, and the family had no idea how to administer insulin, how to check the glucose. Because as you imagine, when they're discharged from the hospital, they're just completely overwhelmed with information.
Yeah.
And they probably only remember a small part of that. So we can go into these homes and reinforce that. And our PA fortunately was there to teach the family how to log and check blood glucose and how to give insulin and which insulin meant what. And it was a great visit.
Now, here comes the amazing part of the story, because when you and I first talked, it really got me. I mean, it snapped my head back when you were talking about you started with one unit and then brought a second unit online, and then, we're overwhelmed with the positive response to it. And then now you're up to 4 units. So tell me how that started and what the volume is currently.
Yes, sir. So we did start right away with CC 109. These units are called Community Care Response Units. So we call them CCRUs. And so Captain Perryman got up and running right away with CC 109, because we were pretty much there at the launch point to begin with. So he was the fastest resource out the door. And then the next unit to launch was the next week. We launched one in the south part of the county. So just to give you an idea of the area that we cover the entire county. So all of Sacramento County, from the far south to the far north, far east to far west. So because we're mobile, we can get there. So Captain Perryman was in the northern part of the county. The second unit to launch was in the southern part of the county. And the third unit to come back up was back in the north area, because Captain Perryman was quite busy, quite busy. And then the fourth unit to came on just this last Monday with the Sacramento Fire Department and CC-15. So now we have 4 up with the potential to go 2 more. We have the ability to stand up to 6.
And logistically, who coordinates? Are you dispatched through the dispatch center? How do you spread the workload?
Again, it's it's Captain Perryman and I that are seeing patients and doing the workload part of that. Our dispatch center is busy as everyone else's is, and this process is very new. Mobile integrated health is not a language that I think your average career person that's been in the fire service or in EMS really speaks unless you've been involved in it. And so asking or tasking our dispatch center to also handle the dispatching of these CCRUs wasn't really necessary, I don't think. And would just add logistical problems that would create potential issues downstream.
So let's talk about volume, because that's what I really want to get at, because I think that's the most positive part of the story is you guys are really, it's not like, you know, you're idle today so that we're killing the other units that are out on the road to help and talk to me. But the reality is we could have all 4 of you busy right now. Go ahead.
Yes, we had 2 of our units are busy right now. We were able to take a break to do this. We've got 1 unit at a skilled nursing facility right now that's administering 11 or 12 swabs to potential patients, again, through the Department of Public Health. We've got a unit in the south that's at a board and care facility right now that's doing some testing as well with several patients there. And then we have assignments in the afternoon. As a matter of fact, when we're done with this, both of these units are going to be going to an assisted living facility that out of their 63 residents has 27 that are positive. And so their entire second floor of their facility has been set aside to handle this crisis. So we go into that facility and we do evaluation. So that's more the post-discharge follow-up. So both of these units will be busy doing that. And then this afternoon, we have more follow-ups. So about the volume, it's really feast or famine, kind of. Yesterday was definitely feast. Yeah, we did a lot of work yesterday. As I mentioned earlier, we did probably 60 swabs yesterday, and it was a very swab-heavy day.
Mm-hmm.
Our total volume so far, so if you go back to April 1st, and we're only Monday through Friday, 9 to 5 right now. There is work that could be done on the weekends, but again, remember that we have volunteers that are giving up their days off, and it's hard for me to ask them to give up their weekends as well. And I don't think the work is as high on the weekends. So Monday to Friday, 9 to 5. I ran some numbers as of last night. We just broached 275 individual patient evaluations last night. We've performed over 160 swabs. Our positive rate is running right around 30%. And I think that the most interesting thing is out of this that we have found is that we're also tracking the clinician's perception of COVID infection. So the usual stuff: nausea, fever, cough, fatigue, sore throat, any of those symptoms. If they don't have any of those symptoms, we're calling them asymptomatic, but we're still being asked to test them. So this is in some of our psychiatric facilities as well, are being challenged with, 1 or 2 positive. They want to try to keep the facility safe. So we may test a large number of asymptomatic patients, and our asymptomatic rate that's COVID positive on antigen testing in the swab is running about 25.2%.
Wow, that's pretty high.
Yeah.
And what about the staff? Are you doing the staff as well?
Yes, yesterday we tested the entire staff at one particular facility at the request of the Department of Public Health. But these are voluntary, right? We can't go in and force them to be tested, but we're finding that people will openly accept us with open arms.
Yeah, that's great. I really think, and I want to talk to Captain Perryman because obviously I've been in the fire service a long time and involved with fire service. And how did you mix the PA with the being a fire captain? Did you go to PA school first or afterwards?
My father worked for LA County Fire Department, and I grew up wanting to be a firefighter, but I also wanted to be an ER doctor. And that's when my dad mentioned Johnny and Roy and putting a firefighter and paramedic together and becoming a firefighter paramedic. That's what I wanted to do. And after I became a firefighter paramedic from my dream job at Metro Fire, I just wanted more. I wanted to get more into the medical side. So I decided to put myself through PA school. That was a significant challenge. but was able to make it. And then during that entire time, I knew that there was a service, or there was a huge missing component to service. And knowing that a mid-level or an advanced provider could fill that gap, I saw that there's a definite need out in the community. And so that's when the work started on mobile integrated health. And, can we just fix this at home, and they can avoid going into the emergency room and the cost of that. And also the comfort of it as well.
I'll bet your fire chief and others are glad that you went and got that extra training, because that really gives you kind of a heads up. And a program like this needs somebody like you who's got that kind of an interest. Now, do you work as a PA when you're not on duty as a captain?
I used to a few years ago. I was doing the fire captain, and I was doing a special project with Mobile Integrated Health, and I was working in the emergency room. And then I also have 4 amazing children and a beautiful wife. And we had the discussion of, would I like to stay married? And I said yes.
I like it. I've read that book. Read that book many times.
So I currently am not, I wasn't practicing clinically for the last few years, but now I'm excited to be able to put them back together again. It's nice to see patients.
Let's turn and talk to our other crew. I'd like to introduce them as well.
We have a couple firefighters from the city fire department that are ready to go. You want their mask on? It'd be harder to hear them, AJ, with the mask on, I think.
No, we're good. And can you just, guys, could you introduce yourselves? You're both from your Sacramento Fire?
Yes, firefighter paramedic Barnick. Yeah, I work for the City of Sacramento Fire Department. I've been there 17 years.
Great.
I'm firefighter paramedic Eric Chin, the City of Sacramento. I've been working there for about 16 years.
Great. Take about 2 steps forward so we're closer to the microphone. Now, I was told before we started that somebody stepped forward and actually used a 3D printer to make those shields for you. Can you tell us who did that, or is that we bring Kevin back in for that?
We'll have to default to Dr. Mackey.
Yeah.
All right, we got room for him. Stay there.
John Perry, can you grab me one of those?
We're good.
Face shields that were made for us?
We're
Yes,
good.
these are industrial face shields, AJ. We're going to show you the face shields that were made for us. It's a gentleman that went to Cal Poly. His business, his background is in business and engineering, and he had offered to us to make these. He 3D prints these, and I'll trade you. I'll just trade them and put this on.
So is he game to share his files with other fire departments to make the masks?
Oh, I'm sure he would be. He's made and donated hundreds of these to the Sacramento area fire agencies and others, including hospitals. He does it out of his home. And then these are fully disposable, which is the benefit. So when we get done using them at the end of the day, we can dispose of them, and we don't have to worry about the decontamination part.
Great. You could take the hood off. I want to be able to talk to you. So what do you normally do? Are you guys engine or truck? What are you?
I'm on truck 43. Signed over there for the last couple of years, and yeah, that's been my assignment.
Are you a medic?
I am a paramedic.
Okay. And how about yourself?
I guess Dr. Mackey wants me to share this with you. I'm also a registered nurse.
Oh boy. You probably, and I'm going to just guess that this is a program that you love getting involved with, right?
As soon as I heard it, it made the little kid in me come out. I was so happy to have an opportunity to put in for it. Our selection process was based off of seniority. And thankfully, I was able to hop in and be on the first wave of this. It's definitely bringing together my skill sets and also an opportunity to serve in a different capacity. It's really
How about your partner?
Yeah, I've been with City of Sacramento, like saying, for 16 years. Been at Engine 18 for the last 11. Been a paramedic for 20 years. Almost the same thing. I saw it come up, saw an opportunity to actually make a change and actually feel like I'm doing more for the community during this crisis. And I just had to jump on it. It's been such a huge learning experience just in the past week for us.
Yeah, but listen, it's a dangerous job to do. So obviously you have the right garb, and I guess your emergency management has been providing you with a lot of good PPE, which is hats off to them. But it's still dangerous. You're going into the soup. It's like a first attack on a fire. you know, when you're going in that nursing home, you're probably going to be in contact with somebody that you're swabbing that has it. So how do you feel about that?
Honestly, I feel very comfortable. We've been trained how to don our PPE, how to decontaminate it to keep us safe. And I feel like you said, going into a fire, we don't know what to expect, but we're ready and prepared to go in, face it. So I believe with research, with all the research data that we're collecting through our own testing and around the nation, I think we'll be able to beat this and figure out how to keep everybody safe.
I've always talked about the red devil when we talked about firefighting, and now we're talking about an invisible devil, with about 25% of those patients being tested that don't really show symptoms, asymptomatic, coming up as positive. That means that it's out in the community. I think it's further out in the community than we're aware of. I would say to you guys, the spread throughout your program, one of the things that people who advise me are telling me is that particularly the guys from back at FDNY, they got to get more sleep. If your resistance is down and you get it, you're strong firefighters, you're going to be able to fight it. But if your resistance is down, if you're not well fed, so, you know, I'm telling your fire chiefs, they better buy you some steak dinners or something to make sure that this thing happens. It really hats off to you. Kevin, do you guys want to come back in the frame here?
Sure, absolutely.
No, you guys could stay. You guys could stay. Yeah, they could stay, sure. The more the merrier. You know, I just think, you know, the volume of it, you've been talking about this for a couple of years. Has funding been a concern about how you're going to keep this, how you were going to start it? I mean, now it's, you know, Katie bar the door, you've started a program that I don't think anybody will want to stop now. And hopefully I'm believing, and maybe I'm wrong, but I've been kind of a visionary that with every disaster I've been involved with, there's opportunity. And with CMS changing codes and allowing treat at home and all those other things, I don't think they're ever going to be able to go back. I think that we're going to always find through public health that we screwed up a little bit. And it's always been ridiculous that we couldn't take somebody to another facility other than a hospital. And so I think we're going to be going to urgent care centers and doing all those other things. Now, you're also handling lower priority calls. Tell me how that happens.
So the lower priority calls we're handling are mostly engines or ambulances or both that get on scene and that identify a minimally ill patient that maybe has symptoms of COVID-19. We can go to their homes, we can do the testing. We have also been able to engage in our unhoused community. There is a whole nother piece to this, AJ, that there are 40 medical students that are upper division, fourth year, third year medical students from UC Davis and California North State University that are on their breaks from their rotations that are volunteering their time to service in our unhoused community, our unsheltered. So we are able to also engage with them when they find individuals that need testing, or we've actually been able to go in to those communities as well and just do simple procedures, prescribe antibiotics. We ran into one lady that was hypertensive that says, yes, I ran out of my medication a few months ago. We're able to get her another prescription. And then we had another guy that was working on his bike, right, Captain Pearman?
Yeah, we've had two stories of where the homeless encampment team called us out there, and one was they were worried one individual might have COVID, and to see if we could screen her for being COVID or not. We went out there and determined that she just simply had strep throat. There was nothing that showed that it was COVID, that it was strep throat. So we were able to fix her. That was a great feeling. And while we were there, another individual came up and said that he may have gotten something in his eye from fixing his bike. We were able to determine that, yeah, he had a little piece of metal. We were able to get that out, give him the antibiotic, the stuff that he needed to make sure that his vision was going to be intact for a long period of time to come.
So right now, I'm assuming nobody's getting billed. Am I right?
Yes, that's why we were both smiling at each other, because that is the holy grail, I think, of any MIH program. And where we have been at this stopgap for several years has been getting the financing to have the proof of concept. And the beauty of this disaster, and there has been, I mean, I could write a book on the silver linings in this disaster. I know it's been horrible and it's affected a lot of people's lives, but a lot of good has come out of it too. And one of the things we've been able to do now is to stand up a proof of concept to our to the payers and to the hospital systems locally to say, look, this thing can really work and we can help you. And I can tell you that I have become the best friends of many hospital discharge planning groups because we're solving some of their tough to solve problems.
Well, I think what I understand from California is that Medi-Cal and other things will pay, particularly if you have a PA, a physician, others involved. They're a little stickler right now with paramedics, but your model, I believe, even after this, would be able to get some reimbursement. And I could tell you, if my mom was in a nursing facility and I could be sure that your units would go check on her, I'd pay some money too. So I think that out of all of the horror that's happened with this whole 19 scenario, there's going to be some good that comes out of it, particularly financially.
There's one aspect that I want to point out is how much collaboration has transpired because of this. We've all
Step forward just a little bit.
We've all known that this is a horrific time for so many people, and we're trying to look at the positives. And the one thing that we've noticed is how much collaboration has transpired and how many barriers have been broken. When you look at this system right here with so many different fire agencies, with so many different hospital agencies, and everybody has come together and worked together to solve a problem, it shows that boundaries can be crossed, and they can work together when there's an actual, when people have the actual desire to make it happen. And unfortunately, COVID-19 made that happen, but we look at the boundaries that have been crossed and the communication and the collaboration, and we're able to make something beautiful to make it better for those folks we've sworn to protect.
Well, Kevin, as I've talked to you when we framed out the article, it's going to be in GEMS. We're going to want a lot of data. You're taking a lot of data. And I think that's going to be important for the success of the program after this. The after action really is going to be the proposal to the hospitals. The hospitals will want to see what that data is, and when they begin to realize how many patients we can impact, I think that they'll kick in and help fund the program. The fact that your Department of Public Health was the instigator in this is magnificent, because now they know the value of the program. It's something that they can't do, but they need to have done. And I think that's wonderful. Kevin, you've been president of the California Emergency Medical, Directors Association, am I right?
You got it.
And,
right.
And still do clinical work at Kaiser, South Sacramento?
Yes, sir, I do. 50% clinical.
You're a wild man, still involved with USAR and still serving on the board of directors for the National Registry. You are, clinically my hero and professionally my hero. I mean, I think, that's the next step. And Captain, I think down the road, you could step back and go to medical school. If you could go to PA school, I think you could finish with medical school. And, to me, you'd be a great medical director somewhere. And the last thing I want to salute are your fire chiefs, because honest to God, I hear from a lot of fire chiefs that are not interested in community paramedicine. And the fact that you have all of those fire chiefs involved in this program, man, I give you a big thumbs up. So, the 2 invites, obviously. Kevin, I want you to submit to present at EMS Today. And Scott, I'd love to have you do the Perryman show at EMS Today. So go on to emstoday.com and submit a couple of proposals. But, I think by the time we get to EMS Today, which will be in San Antonio next year, there'll be a lot of data that you can present. And I really want to thank you all for being with us. All you engine guys, I personally am a truckie myself, but you could see from my size that they like me to fall through the roof rather than you. So you guys come and fetch me when I go in there. But those days are over. My days of sucking up smoke. I have comorbidity factors, including my weight. And so I'm hiding from that devil. That little devil's got to go away for me. But I salute you all. I thank you. And once again, to the fire chiefs, you are our heroes as well. So AJ Heitman, I'm going to be signing off and welcome you back to see another show in the future.